Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds, an EMDRIA and EMDR Europe accredited trainer and consultant. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, student, a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to draw your attention to the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture practice and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. To access any of the original research papers mentioned in the podcast, you will find a complete list of references and links to each of these studies in the December 2025 blog on sonomapti.com. Just go to ti.com, click on the blog section on the far right of the menu bar, and then select the December 2025 listings. You will also find a direct link to these references in the show notes. So let's get started. In today's episode 5 of EMDR, the science behind the therapy, we will cover a range of recent research papers on EMDR therapy. The first group of papers add to our knowledge of group-administered EMDR therapy. One paper compares EMDR teletherapy with in-person EMDR therapy for veterans with PTSD. Then we have a review on the treatment of complex PTSD with Schema therapy, Imagery, Rescripting therapy, and EMDR. Next, we will consider a provocative paper that asks the question, does psychotropic medication reduce the benefit of intensive therapy? Then we look at additional experimental evidence that bilateral stimulation increases frontal EEG activity and reduces autonomic arousal. Finally, in a featured segment, we will look at a randomized controlled study of the psychological and immunological benefits of EMDR therapy for patients with Hashimoto thyroiditis. This will lead us back to 2 earlier remarkable studies showing epigenetic and methylation changes with EMDR therapy that can help explain the potential beneficial effects of therapy in autoimmune conditions. Then we will explore 3 papers dealing with the use of therapy in patients with psychoses, including a unique study carried out in a secure forensic hospital. Finally, we will close with mention of an open access special issue of Clinical Neuropsychiatry with 16 articles by contemporary scholars exploring the importance of considering attachment theory in treating survivors of early neglect and abuse. So let's get started with a series of new research articles on the use of group EMDR therapy. In a 2025 experimental study by Dinch and Kilich, the authors used a quasi-experimental pre-test and post-test design with an experimental and control group to assess the effectiveness of a group therapy program in reducing exam anxiety among middle school students. They identified 20 7th and 8th grade students at a middle school in Turkey during the 2021-2022 academic year who all showed elevated test anxiety on the West Side Test Anxiety Scale. They randomly assigned them to EMDR group therapy or a waitlist control group. They measured test anxiety with the West Side Test Anxiety Scale at pretest and gathered data on age, gender, and grade level. Pretest means were similar in both groups. An EMDR-trained therapist delivered 8 weekly 60-minute sessions to the experimental group using the group traumatic episode protocol. At post-test, the students receiving group EMDR therapy showed significantly less test-taking anxiety. No significant change occurred in the control group. Limitations in this study included reliance on self-report data, small sample size, limiting generalizability, and the absence of follow-up assessments or alternate treatment groups. The structured 8-session duration lacked comparison to other potentially shortened therapies and focused primarily on middle schoolers preparing for high-stakes exams. This study demonstrated that the group traumatic episode protocol could be a promising school-based approach for alleviating exam anxiety, warranting further research on long-term effects, larger samples, and broader student populations. Nicholas Sholiak and co-authors published a 2025 retrospective pilot study at the Psychotrauma Regional Center in Lyon, France, to evaluate the feasibility, acceptability, and effectiveness of a modified group traumatic episode protocol for forced migrants diagnosed with PTSD. They included 71 adult participants, asylum seekers, refugees, undocumented migrants aged 18 to 62 years who attended at least one group session between 2021 and 2024. Groups of 4 to 10 participants received weekly sessions led by one trained EMDR therapist, assisted by 1 or 2 others, incorporating 2 psychoeducation and stabilization sessions, followed by 3 to 4 trauma processing sessions using standardized worksheets, and then 1 reintegration session, translators assisted as needed. Participants self-administered bilateral stimulation by tracking their hand between safety and disturbance indicators on their worksheets. Self-report measures included the PTSD checklist for DSM-5, the PHQ-9, the abbreviated WHO Quality of Life Scale, and SUD ratings collected at the second session and at the last session. Main findings showed significant reductions in PTSD symptoms. PTSD checklist for DSM-5 scores dropped nearly 12 points with a large effect size. Depressive symptoms also decreased significantly. Complex PTSD diagnoses fell from about 61% to about 15%, with 50% reporting no PTSD disorder symptoms at post-intervention. Secondary findings showed high session attendance at 80% average and a low dropout rate of 15% despite unstable living conditions. Limitations in this study included the retrospective design without a control group, missing data, reliance on self-reports and clinical interviews rather than clinician-administered tools, uncontrolled confounds like pharmacotherapy or ongoing stressors, and no follow-up to assess stability of treatment effects. The adapted group EMDR protocol demonstrated acceptability and promising effectiveness for treating PTSD, including many complex cases in forced migrants, supporting its real-world clinical benefits and indicating a need for randomized trials with long-term evaluations. Mustafa and co-authors published a 2025 study to evaluate an Urdu translated, culturally adapted, single-session EMDR integrated group treatment protocol for ongoing traumatic stress among adolescents in Pakistan. They used a single-blind, two-arm randomized controlled trial with a waitlist control group. They translated and adapted the protocol using forward and back translation and a planned adaptation approach with inputs from experts, parents, teachers, and school administrators. They recruited 120 secondary school students aged 11 to 16 years from 2 government schools in Rawalpindi in 2022. The students were screened for psychological distress. Then they randomized 94 eligible students into EMDR and control groups, with the intervention delivered in subgroups of about 10 to 12 participants by a trained EMDR practitioner supported by an emotional support team. The primary outcome measure was the Urdu version of the Depression, Anxiety, and Stress Scale. Fidelity was rated by 2 independent EMDR-trained observers to assess adherence to the protocol. Main findings showed substantial protocol fidelity. Participants rated the intervention as helpful, stress-reducing, safe, and recommendable. Psychological distress scores in the EMDR group decreased from a mean of about 19 at pretreatment to about 6.5 at post-treatment and 6 at follow-up, while waitlist control scores remained stable at around 16, yielding significant main and interaction effects. Secondary findings indicated marked reductions in SUD scores after the single group session. Thematic feedback from adolescents and teachers supported the protocol's feasibility in school settings with no reports of harm. The waitlist group showed no meaningful change until they later received the same intervention. Limitations included reliance on a school-based convenience sample from one district, exclusive of adolescents with severe mental illness or ongoing treatment, self-report measures without clinician-administered diagnostic tools, and a single 3-month follow-up. This trial provided initial evidence that a culturally adapted Urdu single-session EMDR group protocol delivered in schools was feasible, acceptable, and efficacious in substantially reducing psychological distress and traumatic stress among Pakistani adolescents, and it highlighted the need for larger randomized trials to confirm its broader effectiveness and explore effects on comorbid conditions such as depression. Palin and co-authors conducted a quantitative randomized controlled trial to assess virtual delivery of the EMDR group traumatic episode protocol as an early intervention for wartime psychological distress among Ukrainian mental health clinicians. They recruited 63 participants aged 24 to 64 from a mental health center in Kyiv who experienced ongoing trauma during the Russian-Ukrainian war in 2023. They used blind random assignment to form an intervention group of 33 and a waitlist control group of 30. Facilitators trained in the protocol administered 2 60-minute online sessions on consecutive days to subgroups of 8 to 16 participants each, using Ukrainian translated worksheets for self-administered bilateral stimulation using eye movements between points of disturbance on participants' worksheets. Participants completed the PTSD checklist for DSM-5 and the PHQ-9 at pre-test before the first session, at post-test immediately after the second session, and at the 6-week follow-up. Main findings were significant reductions in the intervention group with PTSD checklist for DS to 16 at post-test and remaining at 16 at follow-up. PA9 median scores decreased from 8 at pretest to 6 at post-test and 4 at follow-up. Probable PTSD cases fell from 10 to 3. No severe depression persisted post-intervention. Secondary findings included no significant changes in the control group. Limitations included the use of a convenient sample of highly educated clinicians, which restricted generalizability, an underpowered sample of 63 due to wartime constraints, and assessment timing mismatches because the post-test occurred immediately after sessions, despite the written instructions referencing the past 2 weeks or 1 month. In this remarkable study, the virtual EMDR group traumatic episode protocol, delivered remotely during ongoing war, reduced both PTSD and depression symptoms substantially among these dedicated clinicians, despite the lack of a safety window, supporting its use as scalable early intervention in conflict zones, pending larger trials with more diverse populations. We'll conclude this section on group EMDR therapy with a qualitative study from Torselia and co-authors published in 2025. They used semi-structured interviews to explore frontline healthcare professionals and volunteers' experiences with the EMDR integrated group treatment protocol during COVID-19's first wave. They sampled 20 participants aged 24 to 68 from an Italian health authorities program that had delivered 4 weekly in-person group sessions of 8 to 12 participants, starting with psychoeducation, safe place visualization, and then reprocessing trauma via drawings using the butterfly hug. Main findings showed that initial unfamiliarity evolved to relief. Reprocessing targets blended pandemic and past traumas. Varied bodily reactions led to lightness. Group psychoeducation, butterfly hugging, and group cohesion were described as key elements in reducing distress. Secondary findings noted specific memories, like patient deaths, were linked to prior feelings of helplessness. Some participants needed individual follow-up. Many participants reported strengthened work bonds. Limitations included a single center sampling of 20 and potential desirability bias despite independent interviewers. The authors reported their insights for psychotherapists conducting group EMDR therapy in emergency contexts. They found psychoeducation and describing EMDR's theoretical underpinnings can help recipients fully benefit. They advised adequate time to be reserved to create a safe environment. They suggested future research should address the longer-term impact of group EMDR through longitudinal follow-up of recipients, which participant characteristics shape and successful engagement with EMDR in the group setting. Before we leave this topic, for those who would like to see a comprehensive listing of research on group EMDR therapy, just head over to somapti.com, then click on EMDR Research in the menu bar. Scroll down a short way to the red sidebar menu, where you will find the quick link to the many studies on group therapy. Fairbanks and co-authors published a 2025 multi-site retrospective chart review of 279 U.S. veterans who received EMDR therapy within Veterans Affairs clinics. They compared telehealth and in-person EMDR therapy in routine practice. Inclusion required a PTSD or other trauma and stressor-related diagnosis. EMDR therapy, session gaps under 8 weeks, baseline scores on the checklist for the DSM were used. Symptoms were measured at baseline, mid-treatment, and termination with the PTSD checklist for the DSM and depression with the PHQ. They reported EMDR therapy yielded large reductions in PTSD symptoms and medium reductions in depression with these EMDR-treated veterans. Symptoms declined from baseline to mid-treatment and further at termination. Nearly half completed treatment, with many achieving reliable and clinically significant change on both measures. Telehealth and in-person modalities were largely comparable, although in-person EMDR therapy showed modestly larger PTSD reductions from initiation to termination. Army service, Vietnam-era service, combat trauma, and primary PTSD diagnosis predicted a preference for in-person therapy, while Air Force service and no deployments favored telehealth. Mid-treatment modality switches did not affect outcomes. Limitations in this review included the non-random convenience sample, lack of random assignment or fidelity checks. Further limiting generalizability were racial ethnic underrepresentation, missing data from inconsistent measurement, use of self-report versus clinician assessments, and lack of documentation of the telehealth adaptations. In this study, EMDR proved effective for veterans' PTSD and VA settings, with both modalities producing similar improvements, reliable change, and completion rates. Flexible modality options, accommodating preferences, enhanced access. Future randomized trials should evaluate telehealth adaptations to help guide VA policy. Next, we turn to a 2025 case study exploring the effectiveness of combining schema therapy, imagery rescripting, and EMDR therapy to address the complexities of treating complex PTSD. Van Hemmet and co-authors published the case of an 18-year-old woman with complex PTSD stemming from childhood neglect, domestic violence, and sexual abuse by her stepfather. Treatment spanned 50 sessions in 3 phases. Marie initially declined therapy as too overwhelming. Therefore, sessions 1 through 20 built the therapeutic alliance, developed the case conceptualization using schema therapy, reduced dysfunctional coping modes via chair dialogues, and used imagery rescripting to address experiences of emotional deprivation. After these gains, sessions 21 through 40 focused on trauma reprocessing with therapy for sexual and physical abuse incidents. Sessions 41 through 50 emphasized relapse prevention, emotional regulation, and follow-up. A more detailed discussion of Marie's treatment can be found in the open access article in the European Journal of Psychotraumatology. Assessments occurred at intake, at session 50, using the structured clinical interview for DSM-5 disorders. Experiences in close relationships revised for attachment. Clinician-administered PTSD scale for DSM-5 for PTSD severity. The Young Schema Questionnaire, long form for maladaptive schemas, and schema mode inventory for modes. The Working Alliance inventory monitored the therapeutic relationship in the early sessions. The clinician-administered PTSD scale for DSM-5 scored from 50 at intake, D6 at session 20, reflecting temporary symptom exacerbation as protective modes diminished, then fell to 30 at session 40 and fell to 12 at session 50, indicating full remission below the clinical cutoff. Significant reductions occurred in Young Schema Questionnaire, including unrelenting standards hypercriticism, self-sacrifice, and dependence incompetence, with all scores below 3 by session 40. The schema mode inventory showed decreases in detached self-soother, demanding hypercritical parent, and vulnerable child. Working Alliance inventory scores confirmed a strong, stable therapeutic bond, peaking during imagery rescripting. Marie disclosed deeper traumas towards the middle of treatment, tolerated emotional vulnerability without dropout, and reported fewer flashbacks, nightmares, panic attacks, irritability, and improved self-esteem by termination. Van Hemert and co-authors noted limitations of the single case design, including lack of generalizability, potential underreporting on self-reports due to avoidance and mistrust, a limited number of assessment points obscuring symptom trajectories, absence of a control condition, and unclear sequencing effects of imagery rescripting. They concluded that by integrating schema therapy Imagery, Rescripting, and EMDR, one can effectively treat PTSD by first stabilizing schemas and coping, then targeting trauma, yielding remission and schema reductions in this personalized phase approach. They suggested randomized trials should test this combination against monotherapies to optimize sequencing for diverse patients. Those interested in further case reports on the use of EMDR therapy for individuals with complex PTSD will find other recent reports in the references list in the December 2025 blog on somapti.com. These include single case reports from Hafik Meyer and co-authors 2023, and de Jong and Hofkeetmeyer 2023, and a case series from France published in 2024 by Rowling and co-authors. Clinicians treating individuals with PTSD in real-world settings face the potentially confounding effects of patients taking a variety of psychiatric medications. Do these medications assist in the EMDR treatment outcomes, or do they adversely affect treatment response? This is the question addressed by Steenen and co-authors in a paper published in 2025. They carried out a prospective cohort study at a Dutch psychotrauma center from 2021 to 2024. They examined and analyzed data from over 6,000 adults with chronic or delayed onset PTSD. Their research emulated target trials using machine learning to assess psychotropic co-medication effects on psychotherapy outcomes. Their design adjusted for 27 baseline covariates, including demographics, severity assessed with the CAP scale for DSM from pre-treatment over the past month to 10 days post-treatment over the past week. They assessed complex PTSD via the International Trauma Questionnaire, other comorbidities via the MINI for DSM, as well as trauma history, suicidality, prior psychotherapy, and other medications. Participants underwent a standardized 28-day program of daily prolonged exposure for 90 minutes, EMDR therapy for 90 minutes, and group psychoeducation delivered by a rotating set of licensed psychologists. The primary outcome revealed a mean clinician-measured PTSD scale for DSM-5 decrease of 25.7 points overall. Use of any psychotropic medication was linked to a 2.5-point smaller improvement and a 9.4 relative reduction persisting at 6-month follow-up. Antidepressants in general showed a 0.65-point reduction. However, amitriptyline showed a 10.5-point reduction, and mirtazapine showed a 6.8-point reduction. Similar trends were found for anticonvulsants, antipsychotics, fluoxetine, zolpidem, and zolpidem. Secondary findings at 6-month follow-up confirmed reduced gains for any psychotropic use and antidepressants. Limitations in this study included potential residual confounding by unmeasured factors such as co-occurring personality disorder or medication adherence. Pre-existing medication use precluded new user design. Steenen and co-authors concluded that psychotropic co-medications, especially amitriptyline and mirtazapine, were associated with diminished trauma-focused psychotherapy benefits in this 28-day intensive treatment program for PTSD. They suggested that future trials explore medication tapering or substitution to optimize treatment outcomes. Next, we look at a laboratory study exploring whether persistent exposure to a visual reminder of a trauma enhances the effects of the bilateral stimulation used in EMDR therapy. Newedges and co-authors in the Netherlands conducted a randomized experiment with 136 non-clinical participants to examine if a visual cue boosted dual task interventions for aversive memory desensitization. Participants viewed a vivid 2.5-minute assault scene from a French film that had previously been found to produce intrusive memories. They rated their subjective units of distress and vividness pre-intervention. Note, these authors referred to the bilateral eye movements used in the study as a working memory task. So when you hear working memory task in the summary, it refers to the use of sets of bilateral eye movements. Participants were assigned to one of 4 tasks. The first was recall during a working memory task with a trauma scene screenshot background during ball tracking with keyboard responses required when the ball changed shapes. The second was recall during a similar working memory task, but without the trauma scene background. The third was recall only. The fourth was the working memory task only, tracking the moving ball. Outcomes included distress and vividness ratings immediately post-intervention and 1 week later. They also used other scales, such as for treatment acceptability and adherence. The main finding was that adding a continuous visual retrieval cue to a dual task intervention did not enhance memory desensitization in this study with non-clinical participants. Instead, the researchers found that data more suggested that continuous reactivation of aversive memories during a dual task intervention may not be necessary for effective memory desensitization. In other words, in standard EMDR terms, in this non-clinical study, even minimal disturbing memory activation combined with bilateral eye movements was sufficient to achieve desensitization. Limitations included that self-reports showed no increased film thinking occurred with the background screenshots. The unconsolidated lab memory, non-clinical sample, and low power for small effects limited generalizability. Ongoing visual cues failed to enhance desensitization. Instead, minimal prior activation with bilateral eye movements sufficed, casting doubts on any need for continuous reactivation. In November 2025, Marcus Stengel and co-authors published a laboratory study of the effects of bilateral stimulation. They summarized findings from a series of earlier reports of EEG and physiological studies of EMDR therapy. In their current study, they employed a counterbalanced within subjects design with 20 female PTSD patients and 20 matched healthy controls in a single session featuring 4 blocks that varied the type of memory being recalled and the type of bilateral stimulation, whether eye movements or tactile. They examined frontal brain activity with EEG to assess overall electrical power and the range of brainwave frequencies. They also monitored physiological responses with chest sensors that captured heartbeat timing, the delay between heart pump, breathing rate, and heart rate variability. They compared measurements taken just before and right after the bilateral stimulation, using statistics that accounted for participants' ages to spot distinctive changes. Both eye movements and tactile stimulation significantly increased frontal EEG total power, decreased spectral edge frequency, and reduced autonomic activation, as shown with higher heart rate variability and lower respiration rate. This was consistent across groups and memory conditions. The PTSD patients reported greater distress on the impact of event and subjective units of disturbance scales, yet physiological changes showed no group or memory differences, showing that the PTSD subjects experienced the same degree of adaptive changes as the control subjects. Limitations in this study included imprecise EEG measures with source localization, lack of eye tracking, not using the full EMDR protocol, relatively short bilateral stimulation periods, different kinds and degrees of trauma history in a female-only sample. Despite these limitations, the authors reported that bilateral stimulation from either eye movements or tactile stimulation consistently enhanced frontal EEG activity and autonomic de-arousal. This occurred irrespective of modality of bilateral stimulation or memory content, supporting a role for EMDR therapy for top-down regulation of limbic activation, leading to emotional reprocessing effects. Next, we turn to our featured article, which addresses a remarkable question. Can EMDR therapy modulate the activity of the immune system, provide benefit for those with an autoimmune disorder? This is a just published randomized controlled trial from November 2025 investigating psychological and immunological benefits of the EMDR therapy in Hashimoto thyroiditis. Marie Magdalena Makarenko and co-authors carried out their study through the Department of Psychology and Cognitive Sciences at the University of Bucharest in Romania. Hashimoto thyroiditis is an autoimmune endocrine disorder in which the immune system destroys thyroid tissue, leading to chronic inflammation and eventually to hypothyroidism. The authors explained that it is the most common autoimmune disease worldwide and disproportionately affects women. Treatment is typically limited to thyroid hormone replacement therapy. Environmental factors such as childhood adversity have been shown to dysregulate the hypothalamic pituitary adrenal axis and reduce thyroid hormone availability, thereby contributing to autoimmune vulnerability. They point out that only one prior RCT by Marco Manaloke and co-authors in 2019 had evaluated a psychological intervention specifically for patients with Hashimoto thyroiditis. That 2019 study showed modest effects on antibody levels and mood symptoms. In the current study, Makarenko and co-authors examined the effectiveness of EMDR in improving psychological functioning and modulating immune markers in adults with Hashimoto's thyroiditis. 91 adults with Hashimoto's thyroiditis were assigned to EMDR plus treatment as usual, placebo plus treatment as usual, or treatment as usual alone. Participants in the treatment as usual group received standard medical care, primarily levothyroxine. The placebo condition served as an active control. Participants in the placebo group had weekly supportive therapy focused on present and future concerns. Therapists offered empathy, validation, and psychoeducation, but avoided trauma narratives or reviews of past events. This active placebo design maintained non-specific therapeutic factors like alliance and expectancy while excluding EMDR's trauma reprocessing component. Participants in the EMDR group received standard EMDR therapy delivered by EMDR Europe certified clinicians following the standard 8-phase EMDR protocol. Case conceptualization was based on the two-method approach described by Jung and co-authors in 2010. Participants reprocessed 10 traumatic memories that had occurred prior to their illness onset. Clinicians received regular supervision from EMDR Europe accredited supervisors and fidelity checks based on their session notes. Trauma history was assessed using an abbreviated version of the Maltreatment and Abuse Chronology of Exposure Scale, or MACE scale, developed by Scher and Perriger 2015. Additional measures included the Romanian versions of the Toronto Alexithymia Scale, the Dissociative Experiences Scale, the State Trait Anger Expression Inventory, the Depression, Anxiety, Stress Scales, the World Health Organization Quality of Life Scale, and the Difficulties in Emotional Regulation Scale. Process measures included the Outcome Rating Scale and Session Rating Scales, and the Intent to Attend Scale. Of the 91 participants initially enrolled, attrition varied by condition. The EMDR group had a low attrition rate of 3% because one participant failed to return questionnaires. The placebo group experienced no attrition. In contrast, the treatment as usual group had a much higher attrition rate of 29%. This was primarily due to treatment as usual participants starting psychotherapy, starting psychotropic medication, or becoming unreachable. Outcomes included antithyroid peroxidase, anti-TPO, and antithyroglobulin, anti-TG levels, and the just mentioned psychological measures assessed at baseline, post-treatment, and 3-month follow-up. After 10 reprocessing sessions, those in the EMDR group showed significant improvements in dissociation, alexithymia, depression, anxiety, stress, trait anger, and emotional regulation, along with enhanced quality of life. These effects were maintained at follow-up and generally exceeded those in the placebo or treatment as usual groups. A significant reduction in antithyroid peroxidase levels was observed in participants in the EMDR group with a sustained effect at follow-up. Those in the placebo group showed similar reductions in antithyroid peroxidase levels. These were novel and significant findings. No significant effects were observed for antithyroglobulin. There were a number of notable limitations in the study. First, while the total sample size was sufficient for a 3-arm randomized trial, the number of participants per condition was modest. Second, psychological outcomes were only measured with self-report instruments. Third, therapist blinding was not possible. Fourth, while the study assessed changes in anti-TPO antibodies, no intermediate physiological markers such as cortisol or pro-inflammatory cytokines were assessed. Fifth, the extreme imbalance in group sizes with 89 women versus 2 men prevented statistical comparison by sex. Sixth, a longer-term evaluation of 6 to 12 months will be necessary to assess the durability of EMDR's psychological and immunological effects in chronic autoimmune conditions. In addition, online recruitment through Facebook may have introduced a selection bias by potentially favoring individuals more health-aware and motivated to seek psychological support. Finally, the placebo condition was intended to be a time and attention-matched control. However, it also involved empathic listening, emotional validation, and structured support, making it more of an active comparator than a true placebo control. To address these issues, the authors recommended that future studies include larger samples, mixed method assessment strategies, broader recruitment, longer-term follow-up periods, and more biological mediators to clarify mechanisms of action. This first-of-its-kind study is important for several reasons. It showed that EMDR therapy offers promise as an adjunctive treatment for adults with Hashimoto's thyroiditis. EMDR therapy delivered significant improvements in a range of psychological symptoms, including decreased association, depression, anxiety, stress, trait anger, and emotional regulation difficulties. EMDR therapy participants reported enhanced quality of life greater than in the placebo and treatment as usual at 3-month follow-up. A notable within-group reduction in anti-TPO antibody levels occurred in the EMDR arm, suggesting potential immune modulation. These preliminary results support the incorporation of trauma-informed care in autoimmune management via psychoneurological pathways. The authors called for larger trials with longer follow-ups, more diverse samples, and a broader range of biomarkers to confirm immunomodulatory effects. Now, before moving on to the final section of the podcast highlighting recent research on the EMDR treatment of psychoses, we will briefly review 2 other recent studies of methylation effects from EMDR therapy that are relevant for understanding how modulating autoimmune function might take place. The first is a 2022 study from Kalaman and co-authors who conducted a randomized controlled trial at the Colombian Institute of Family Wellbeing with 44 adolescent girls aged 13 to 16 from Colombia's foster care system. All had experienced 4 or more adverse childhood experiences. Participants were randomized into intervention and control groups. Saliva samples were collected at baseline and post-intervention for genome-wide DNA methylation analyses using the Illumina Infinium Methylation EPIC B chip system. Psychological measures included the short PTSD rating interview, child PTSD symptom scale, and mindful attention awareness scale for adolescents. The intervention group received a 1-week residential program with yoga, loving kindness meditation, mindfulness, artistic expression, and EMDR group sessions on days 5 and 6, while controls did standard holiday activities. DNA data underwent normalization and filtering to 688,000 sites. Main findings showed 49 differentially methylated loci, mostly in gene bodies, in neutral, immune, endocrine, cancer, diabetes, and cardiovascular pathways. 2 of these methylation changes correlated with improvements in the child PTSD symptom scale and the short PTSD rating interview. Limitations included small sample, saliva, tissue limitations, absent gene expression data, and no long-term follow-up. Results show that this 1-week intensive multimodal program modulated DNA methylome sites relevant to ACE-related disorders, indicating epigenetic mediation of benefits. More recently, a 2024 paper from Carvalho Silva and co-authors reported on 30 patients with treatment-resistant depression linked to early life stress. 12 patients received trauma-focused cognitive behavioral therapy, and 18 patients received EMDR therapy. They had 3 60-minute sessions weekly for 8 weeks, plus their ongoing medications. Traumatic stress history came from the childhood experiences of care and abuse questionnaire, and depression scores from the Montgomery-Åsberg Depression Rating Scale, with scores collected at baseline, 4 weeks, 8 weeks, and 12 weeks, and relapse checks at 26 weeks. Blood DNA methylation was measured with the Illumina Infinium Methylation EPIC array at baseline, 8 weeks, and 12 weeks. Main results showed 110 DNA regions changed in methylation from baseline to 12 weeks across all patients, tied to genes like LTA and GFL1 for inflammation and mental health issues. Pathways linked to tumor necrosis factor signaling stood out. EMDR patients had 141 such changes with genes like S100A8 and strong inflammation links. Limits included the small group size, no control group, and unclear brain links from blood tests. This study offered early signs that EMDR especially altered DNA methylation in inflammation pathways, hinting at better personalized care and providing a potential pathway to affect genetic pathways modulating the immune system. These 2 studies of EMDR therapy identified changes in DNA methylation patterns, particularly in genes linked to inflammation and immune responses following trauma-related conditions like treatment-resistant depression and PTSD. In patients receiving EMDR therapy, significantly differentially methylated regions were observed in genes such as LTA, GFL1, and S100A8, which are associated with inflammation pathways. These methylation alterations suggest EMDR therapy can influence epigenetic mechanisms that regulate gene expression related to stress and immunity. While EMDR therapy is not a cure for autoimmune disorders, its integration with medical treatments offers a holistic approach to symptom management in conditions like psoriasis, multiple sclerosis, or rheumatoid arthritis that could lead to reducing or preventing autoimmune flares. Next, we turn to our final section of 3 papers dealing with EMDR therapy and the treatment of psychosis. In the first of these papers, we turn to a rarely reported population treated with therapy, inpatients and prisoners with psychotic disorders and PTSD receiving forensic care. Avery Palmer and co-authors published in 2024 a single-blind randomized controlled trial comparing EMDR therapy to waitlist treatment as usual in 24 adults with psychotic disorders and PTSD receiving forensic care in New Zealand. Participants were inpatients and prisoners aged 18 to 65 years, all with diagnoses of psychotic disorders and with PTSD confirmed by the CAPS scale at baseline. They received 9 60-minute EMDR sessions or usual care over 10 weeks. In the EMDR group, there was no period of stabilization before starting EMDR reprocessing. Outcomes were assessed at baseline, 10 weeks, and 6 months by investigators blinded to group assignment. The primary outcome showed lower CAPS scores in the EMDR group after 6 months compared to the control group, with a large treatment effect size of 11, favoring EMDR. Secondary findings included increased Rosenberg Self-Esteem Scale scores, reduced Beck Depression Inventory 2 scores, and lower WHO Disability Assessment Schedule scores at 10 weeks in the EMDR group. No significant differences emerged in psychotic symptoms on psychotic symptom rating scales, social functioning, or trauma symptom inventory 2. EMDR was well tolerated, with 83% completion, high treatment acceptability adherence scale ratings, and no serious adverse effects. Any minor effects were somewhat less in the therapy group. After 6 months, only 17% of EMDR participants met PTSD diagnostic criteria versus 36% in controls. Results favored EMDR therapy across most outcomes without exacerbating psychosis. The authors noted limitations, including the small sample size due to COVID-19 restrictions, wide confidence intervals reducing power for secondary analyses, lack of participant blinding, risking expectancy bias, uncontrolled medication use, a change from the CAPS from version 4 to 5, introducing potential measurement variability, and a fixed 9-session cap that was insufficient for multiple traumas. Palmer and co-authors concluded that EMDR was safe, acceptable, and effective for reducing PTSD symptoms in forensic patients with psychosis, supporting its use alongside usual care in inpatient prison and custodial settings to address trauma linked to suicidality, violence, and recidivism. Next, the paper accepted for publication in September 2025, but not yet edited for final publication. Ahmed and co-authors conducted a systematic review of randomized controlled trials to assess the efficacy and safety of EMDR in patients with psychosis, comorbid PTSD. Eligible studies included randomized controlled trials investigating EMDR in patients diagnosed with psychotic disorders or exhibiting psychotic symptoms who reported post-traumatic stress symptoms or had an established PTSD diagnosis. The review examined 4 randomized controlled trials involving 275 participants, primarily adults aged 36 to 41 years with diagnoses such as schizophrenia, schizoaffective disorder, or bipolar disorder with psychotic features. Interventions comprised standard EMDR or EMDR for psychosis alongside treatment as usual, delivered over 8 to 16 sessions, compared against treatment as usual, waitlist, or prolonged exposure. A wide variety of standardized measures were used. EMDR demonstrated superiority over treatment as usual and waitlist conditions in reducing PTSD symptoms across clinician and patient-rated scales at post-treatment and follow-ups to 12 months. EMDR therapy consistently improved psychotic negative symptoms and paranoid thinking. No serious adverse events attributable to EMDR occurred. Minor transient exacerbations coincided with trauma reprocessing in some cases. Limitations included the small number of trials, modest sample sizes in 3 of the studies, inclusion of a feasibility study, and relatively short follow-up periods. Quality assessments revealed low risk of bias in most domains, though concerns arose in randomization and missing data for some studies. Ahmed and co-authors concluded that EMDR therapy offered a safe and promising therapy for reducing PTSD and select psychotic symptoms in patients with psychosis, warranting larger trials with extended follow-ups to confirm efficacy. Finally, We turn to questions about the use of EMDR therapy for treating individuals who have had a first episode of psychotic symptoms. In a paper published in 2024 in the Journal of the New England College of Clinical Psychologists, Eleanor Baggett employed a single case study design within a reflective practice framework to examine the recent traumatic episode protocol, often referred to as RTEP, to address post-traumatic stress symptoms following a first episode of psychosis. Dr. Baggett provides a brief but thorough review of the literature regarding research on use of EMDR for psychosis and the clinical application of EMDR therapy in first episode of psychosis. She discussed the topic of hallucinations and voice hearing and describes the RTEP protocol for this application in some detail. Clinicians seeking guidance about these issues will find her review quite helpful. The case she presents involved a young adult man several months post-first episode who went a psychological assessment, 5 RTEP sessions, and 1 follow-up session for substance use. She used the impact of event scale revised to measure PTSD symptoms before and after intervention, and subjective reports to capture daily rumination time, anxiety triggers, distress from delusions and voices, cognitions, and overall SUD scores. The main findings showed a complete reduction in impact of event scale revised scores from 16 to 0 after reprocessing 4 points of disturbance. 3 distressing delusions, 2 were sexual, 1 suicidal, and 1 related to suicidal thoughts from voices. The young man changed his beliefs from "there was something wrong with me and I'm nut." Before treatment, he reported 20 minutes of triggering anxiety daily, to post-treatment, he reported he had ceased daily thinking about psychosis, had reduced shame, and felt lighter without distress. He commented positively on his experiences of reprocessing sessions, which helped him to normalize his experiences, reduced his fear, and fostered non-judgmental validation. The author clarified that where clients require a longer-term psychological intervention to address historical memories or other trauma, or would like to focus their treatment more widely than just the episode memories, then the EMDR standard protocol would be more appropriate. In this case, the RTEP protocol offered effective, brief relief from post-traumatic stress symptoms tied to a first episode of psychosis. Before we close, there is a wonderful new set of open access articles on attachment theory in relationship to chronic early neglect and trauma. Listeners who follow the literature on attachment theory will want to explore the special issue of Clinical Neuropsychiatry, Volume 22, Issue 5, for October 2025 on attachment trauma. This open access special issue features 16 articles by contemporary scholars, starting with a lead article by Benedetto Farida and Adriano Schmettani. Other contributors include John G. Allen, Anna Vonderhart, Richard Sheffitz, Constance Dallenberg, Martin Dorahy, Ruth Lanius, and Ellert Nienhaus. A link to all 16 articles can be found at the end of the references for episode 5 of the podcast in the blog post for December 2025. A link to the December 2025 blog post with references is in the podcast show notes. That's it for today's episode of EMDR, the Science Behind the Therapy, from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles covered in this 5th episode of the podcast can be found at sonomapti.com/blog in the December 2025 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit sonomapti.com, and for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks for listening. We'll see you next time.